Hello, everyone. I welcome you once again to another wonderful time with Dr. Ifeanyi Mary Ann Okafor. Welcome to our YouTube channel, a channel where we discuss different topics in hematology and blood transfusion science. Thank you for being part of what we are doing so far. Our last two lectures were on folate metabolism and vitamin B12 metabolism. Hope you enjoyed the lectures. Please keep sending in your feedback. And if you have not subscribed yet, please don't hesitate to subscribe. Thank you very much. Today, we are going to be discussing another exciting topic, megaloblastic anemia. Megaloblastic anemia. Permit me to share my slides with you for today's lecture. Welcome once again to today's lecture. Remember, the topic is megaloblastic anemia. I am Dr. Ifeanyi Mary Ann Okafor, a lecturer in the Department of Hematology and Blood Transfusion Science, College of Medical Sciences, University of Calabar, Nigeria. It is expected that at the end of this class, you should be able to define megaloblastic anemia, have a good understanding of etiological factors that can cause megaloblastic anemia, understand the biochemical basis of megaloblastic anemia, explain general tissue effects of cobalamin and folate deficiency. You should have a good understanding of the clinical and laboratory presentation of megaloblastic anemia, and you should be able to explain laboratory diagnosis of megaloblastic anemia, and obviously how it can be prevented. What is anemia? By definition, anemia can simply be said to be a reduction in the red blood cell volume or hemoglobin concentration below reference level for age and gender of a particular individual. The anemia can be said to be reduction in the red blood cell volume or hemoglobin concentration below the reference level for the age and sex of the individual. WHO defines anemia in children below 5 years and pregnant women as hemoglobin concentration less than 11 grams per DL at sea level. They also defined anemia in non-pregnant women as hemoglobin concentration less than 12 grams per DL. Why World Health Organization defines anemia in men as hemoglobin concentration below 13 grams per DL. Megaloblastic anemia that we are discussing today is a form of nutritional anemia. What is nutritional anemia? Nutritional anemia can simply be defined as anemia that occurs when there is a deficiency of one or more of the essential nutrients required for synthesis of hemoglobin and production of erythrocytes. Nutritional anemia can be defined as anemia that occurs as a result of deficiencies of those nutritional essential nutrients that are needed for production of hemoglobin and in extension erythrocytes. Therefore, deficiency of iron, folate, B12, protein pyridoxine, vitamin C, copper can lead to various forms of nutritional anemia. Previously, we have talked about iron deficiency anemia as the most prevalent form of nutritional anemia. Please, if you have not listened to that lecture, do well to go back and search for it on our YouTube channel, and I bet you will learn a lot from it. Today, we are going to be handling another form of nutritional anemia, which is megaloblastic anemia, that occurs as a result of folate and B12 deficiency, that occurs as a result of folate and B12 deficiency. Now, what is megaloblastic anemia? Megaloblastic anemia can be defined as a type of anemia that has distinctive morphological appearances, which is characterized by abnormally large and immature red blood cells called megaloblasts in the bone marrow, and macrocytosis in the peripheral blood as a result of folate and vitamin B12 deficiency. It is a form of anemia that is characterized by abnormally large and immature red cells in the bone marrow and macrocytes in the peripheral blood. And this anemia occurs as a result of B12 and folate deficiency. It can also be defined as a type of anemia that results from impaired DNA synthesis in the bone marrow as a consequence of folic acid and cobalamin deficiency, leading to the production of abnormally large red blood cells called megaloblasts, leading to the production of abnormally large red blood cells called megaloblasts. Etiological factors. What are those things that can, make an individual to have megaloblastic anemia? We have one, dietary insufficiency. Yes, dietary insufficiency. When you're not taking in enough folate or vitamin B12 in your diet, you are bound to end up with megaloblastic anemia. Remember, folate is gotten from food like vegetables that are predominant in vegetables and lesser amounts in kidney, liver, and organ meat. And when we consume these leafy vegetables, we will get enough of that. And also, vitamin B12 is derived from food of animal origin. Therefore, those people that don't eat meat or fish or egg might end up developing megaloblastic anemia due to B12 deficiency. Another thing that can cause megaloblastic anemia is acquired or congenital conditions that can interfere with either B12 or folate metabolism. Studies have shown that megaloblastic anemia due to deficiency of vitamin B12 is comparatively rare and is usually restricted to undernourished communities who are predominantly vegetarians. who dwell mostly on vegan diets, or people that avoid meat, fish, due to either religious or cultural reasons. Studies have also shown that megaloblastic anemia can also occur in patients or individuals that are infested with tapeworm and other fish tapeworm and other parasites, which diverts the vitamin in the gut lumen to its own use. Now, what are the causes of cobalamin deficiency? We looked at this when we treated the vitamin B12 metabolism, but let us also have an overview, the things that can cause B12 deficiency. We said nutritional. It can be those that are mostly vegetarians. They don't consume meat. They dwell only on vegetables, food from vegetable sources. Those individuals tend to develop B12 deficiency because B12 can only be derived from food from animal origin. Malabsorption, like in pernicious anemia. Remember when we treated B12 metabolism, we said B12 can only, the main protein that is actually involved in B12 absorption is intrinsic factor. This intrinsic factor is produced by the parietal cells of the stomach. Therefore, individuals that lack intrinsic factor can actually develop B12 deficiency because they won't be able to absorb B12 from their diet, and in extension, they can develop megaloblastic anemia. And a form of anemia that occurs strictly as a result of absence of intrinsic factor, either acquired or congenital, is called pernicious anemia. Pernicious anemia is an anemia that develops as a result of individual not having intrinsic factor. Intrinsic factor can be absent as a result of diseases that affect stomach, like gastrectomy, or total or partial gastrectomy can lead to individual not being able to produce intrinsic factor. Or it can be congenital. The person and the individual is born without ability to produce the intrinsic factor. Anemia that occurs as a result of absence of intrinsic factor is called pernicious anemia. So presence of pernicious anemia in extension can also lead to megaloblastic anemia. So malabsorption as a result of pernicious anemia, that is absence of intrinsic factor, can cause megaloblastic anemia. Then congenital intrinsic factor absence or functional ability abnormality of intrinsic factor due to total or partial gastrectomy can also induce cobalamin deficiency. Now, diseases that can affect the small intestine, because remember, the B12 is absorbed at the ileum part of the small intestine. So diseases that can affect the small intestine can also do what? Cause cobalamin deficiency. Remember, B12 is heat resistant and it is abundant in animal proteins. So when we consume animal proteins, we get more of B12. Causes of folate deficiency. Folate deficiency, like that, is folic acid. Causes of folate deficiency can also be dietary, when we are not taking in enough folate in our diet. Remember, folate is heat labile. So when we overcook our food, remember, folate is gotten mostly from vegetables. And when we overcook these vegetables, we tend to lose their folate, reduce their folate content. So dietary insufficiency can also cause folate deficiency when we are not taking in enough, especially in old age, in infancy, that children that don't like vegetable. Poverty, when you don't have enough money to even buy what you need. And then malabsorption, diseases that can affect small intestine. Remember, folate is absorbed at the proximal part of the small intestine. So diseases that can affect the small intestine can also affect folate absorption, and extension lead to folate deficiency. Excess utilization or loss in pregnancy has increased demand of all nutrients, including folate. And if you are not taking in enough, then it might lead to deficiency. The same thing in lactating mothers and then premature babies. There are also pathological conditions that can also lead to folate deficiency. So hematological diseases like chronic hemolytic anemia, sickle cell disease, thalassemia major, myelofibrosis, all these things in extension can lead to folate deficiency. Hemodialysis, those that are undergoing hemodialysis, peritoneal dialysis, somehow, or extraurinary loss in cases like individuals that have congestive heart failure, active liver diseases, in extension can also lead to folate deficiency. Remember, folate is from, we derive folate mostly from vegetables like spinach, yeast, mushrooms, and organ meat like kidney, liver, but they are predominantly found in vegetables. And folate is heat labile, therefore we shouldn't overcook these vegetables. Let us look at the biochemical basis of megaloblastic anemia. The common feature of megaloblastic anemia is defect in DNA synthesis that affects rapidly dividing cells in the bone marrow and other tissues. The common feature that you see in megaloblastic anemia is a defect in DNA synthesis that affects rapidly dividing cells both in the bone marrow and other tissues of the body. This defect leads to decline in the rate of DNA synthesis, leading to a delay in cell division in all proliferating cells. This defect leads to decline in DNA synthesis, leading to a delay in cell division in all proliferating cells in the body. And this defect is actually due to abnormal purine and pyrimidine metabolism and inhibition of DNA polymerization. Remember that folate is needed in production of DNA precursors. So when folate is not there, remember in our folate metabolism, we said the active form of folate is tetrahydrofolate. And this active form of folate is derived in a particular reaction in the system where homocysteine is converted to methionine. And in that particular reaction, B12 served as a coenzyme in form of methyl cobalamin. And in that particular reaction, folate in form of 5-tetrahydrofolate is reduced to the active form of folate, which is tetrahydrofolate. 5-methyl tetrahydrofolate is reduced to active form of folate, which is tetrahydrofolate, which then goes into the cells to help in producing, that is involved in one carbon metabolism and production of nucleic acid synthesis and protein synthesis, and also in the production of DNA precursors like purine and pyrimidine. When this tetrahydrofolate cannot be produced as a result of deficiency of folate or B12, now it will lead to a delay in the synthesis of DNA, lead to a decline in the rate at which DNA is being synthesized, leading to a delay in the cell division in all proliferating cells in the body, both in bone marrow and other tissues of the system. All conditions that give rise to megaloblastic changes share in common a disparity in the rate. They share in common a disparity in the rate of synthesis or availability of 4 immediate precursors of DNA, which are adenine, guanine, the purines, and pyrimidines, thymine, and cytosine, that are required for ordered DNA replication during the S phase of the cell cycle. You should note that in deficiencies of either folate or cobalamin, the defect in DNA synthesis is caused by a failure to convert adequate amount of deoxyuridine monophosphate to thymidine monophosphate. Remember what I explained earlier, that B12 is involved in the production of active form of folate, which is tetrahydrofolate. And this production is done during the conversion of homocysteine to methionine. In that particular reaction, B12 is involved as a coenzyme in form of methylcobalamin. And monoglutamate, which is 5-methyl tetrahydrofolate, is converted to active form of folate, which is tetrahydrofolate. And this tetrahydrofolate is actually what is involved in the conversion of deoxyuridine monophosphate to thymidine monophosphate. And it is needed inside the cell in form of a coenzyme called 5,10-methylene tetrahydrofolate. And when it is not available, there is the conversion of the deoxyuridine monophosphate to thymidine monophosphate is impaired. And this, in extension, leads to delayed synthesis of DNA. Folate is primarily absorbed in the small intestine, proximal part of the small intestine, and it is transported in cells mainly as 5-methyl tetrahydrofolate, which must be converted to its active form, tetrahydrofolate. Now, tetrahydrofolate is required in the methylation of the deoxyuridine monophosphate. So, deoxythymidine monophosphate. In the presence of thymidine synthesis, folate deficiency leads to decreased synthesis of thymidine monophosphate and increased level of deoxyuridine monophosphate. And this imbalance apparently slows down DNA synthesis and delays cell proliferation. The end result of this retardation in DNA synthesis is inappropriate enlargement of the cells, which is called megaloblasts, which contain more than normal amount of DNA, but not enough for cell division. I just give a recap of what I explained earlier, that when there is folate deficiency, because of inability or absence of B12 to convert 5-methyl tetrahydrofolate to active form, which is tetrahydrofolate, deoxyuridine monophosphate cannot be converted to thymidine monophosphate. Therefore, there will be accumulation of uridine monophosphate in the system, and this creates an imbalance, leading to decreased synthesis of thymidine monophosphate. And this imbalance apparently slows down DNA synthesis and delays cell proliferation. Vitamin B12 is involved in the conversion of 5-methyl tetrahydrofolate to tetrahydrofolate, which is required for the methylation of the deoxyuridine monophosphate to thymidine monophosphate. Vitamin B12 deficiency, similar to folate deficiency, leads to disturbances of DNA synthesis and consequently megaloblastic anemia. This is diagrammatic explanation of what I have just described earlier. I said, for you to have active form of B12 in active form of folate in the system, homocysteine is converted to methionine, and the enzyme involved there is methionine synthase. But B12 is involved here as a coenzyme in form of methylcobalamin. And this B12 is needed in the conversion of monoglutamate form of folate, which is 5-methyl tetrahydrofolate, to active form of folate, which is a tetrahydrofolate. It is this active form of folate that is actually involved in 1-carbon metabolism, nucleic acid synthesis, amino acid synthesis, synthesis of DNA precursors. So when B12 is not available, there is accumulation of that. When B12 is not available, there is accumulation of 5-methyl tetrahydrofolate, which we call methyl trap, which in extension will lead to absence of tetrahydrofolate for the conversion of precursors, production of precursors of DNA, and in extension, megaloblastic anemia. Another important reaction that we need to also note is the conversion of propenyl-CoA to methylmalonyl-CoA. This methylmalonyl-CoA at an extension is later converted to succinyl-CoA. In this reaction, methylmalonyl-CoA mutase is served as an enzyme, but vitamin B12 is also needed in this enzyme as a in this reaction as a coenzyme in form of 5-adenosyl cobalamin. This particular reaction leads to the production of succinyl-CoA, which, among other things, is involved in the synthesis of hemoglobin. Remember, the first step in synthesis of hemoglobin is the condensation of succinyl-CoA with glycine. Particular reaction is the first reaction in hemoglobin synthesis. Now, unavailability of B12 in form of 5-adenosyl cobalamin will lead to accumulation of methylmalonyl-CoA. And accumulation of methylmalonyl-CoA, among other things, causes demyelination of nerves and axons, which is actually the main cause of neurological symptoms that we observe in B12 deficiency. What we are trying to show here is by the time that tetrahydrofolate is generated, it enters into the membrane and is used. 5-methyl tetrahydrofolate being converted to tetrahydrofolate enters into the membrane and it is used in the interconversion of serine to glycine and also production of purine and pyrimidines, the DNA, the precursors of DNA, and also production of S-adenosyl methionine, which is helped in donation of methyl group in so many reactions that take place in the system. Let us look at general tissue effects of cobalamin. Like we said, cobalamin and folate deficiencies affect all the proliferating cells in the system, all the cells in the body that undergoes mitosis and meiosis that can be affected by folate and B12 deficiency. So cobalamin and folate deficiencies affect all the epithelial surfaces. These deficiencies, when severe, affect all rapidly growing, that is DNA synthesizing tissues in the body. After the bone marrow, that's affecting rapidly dividing precursors of red cells and blood cells. After the bone marrow, the next most affected tissue are the epithelial surfaces of the mouth, the epithelial surfaces of the stomach, small intestine, respiratory tract, urinary and female genital tracts. Urinary and female genital tracts. So deficiency of B12 and folate can affect, in addition to affecting the bone marrow, that can eventually lead to production of megaloblastic anemia. It can also affect other tissues of the body, all DNA synthesizes tissue and cells, affecting their surfaces, the mouth, the stomach, the small intestine, the respiratory, urinary, female genital tract. It can also cause complication in pregnancy because the gonads are also affected. And infertility is common in both men and women that suffer deficiency of cobalamin or folate. Infertility is common in both men and women with either deficiency of folate or B12. Maternal folate deficiency has been implicated as a cause of prematurity, and both folate and cobalamin deficiency have been implicated in recurrent fetal loss. So it can cause complications like miscarriages in pregnancy, and also it can induce infertility because the gonads are affected. So infertility in male and female can also be traced to deficiency of this important vitamins B12 and folic acid because they are needed in DNA synthesis. Neural tube defect. Folic acid supplements at the time of conception and in the first 12 weeks of pregnancy can reduce by about 70% the incidences of neural tube defects, spinal bifida in fetus. Most of these protective effects can be achieved by taking folic acid like 0.4 milligram daily before consumption and most importantly, within the first trimester of pregnancy. The incidence of cleft palate and hair lip can also be reduced by taking prophylactic folic acid. So what are we saying? Saying that incidences of neural tube defect can be reduced by 70% by taking prophylactic folic acid and extension vitamin B12 before conception, and most importantly, during the first trimester of pregnancy. Folic acid supplementation during pregnancy helps to prevent what we call neural tube defect or spinal bifida. It can also cause cardiovascular diseases. Remember, we are discussing general tissue effect of deficiency of folate and cobalamin. It can induce cardiovascular diseases. Studies have shown that severe homocystinuria, that is increased blood level of homocysteine, that is from 100 micromole per liter and above, the presence of this in children makes them to suffer from vascular diseases such as ischemic heart disease, cerebrovascular diseases, pulmonary embolus as teenagers or even in young adults. Remember, we said that during the conversion of homocysteine to methionine, B12 is needed as methylcobalamin as a coenzyme, and 5-methyl tetrahydrofolate is converted to active form of folate, which is tetrahydrofolate. So in absence of B12 and folate, homocysteine accumulates in the system. And when this is done, it can be a risk factor for chronic heart diseases. It can lead to, cardiovascular diseases, and can also be seen in urine as homocystinuria. Folic acid is required, like I said, for the conversion. Folic acid and folate is required for the conversion of homocysteine to methionine. And deficiency of folic acid and methionine leads to accumulation. Deficiency of folic acid and B12 in the system can lead to accumulation of homocysteine in the system, causing cardiovascular. It can induce cardiovascular diseases. Malignancy. Prophylactic folic acid in pregnancy has been found to reduce the subsequent incidence of acute lymphocytic leukemia in childhood. Studies have shown that prophylactic intake of folic acid during pregnancy reduced to a great extent incidences of lymphoblastic leukemia in childhood. Folate deficiency can also cause reduced regeneration of cirrhotic liver. So in extension, we are saying that folate and B12 deficiency, because they are involved in DNA synthesis, in production of DNA precursors, their deficiencies can increase the risk of having different malignant diseases, because studies have shown that women that take folic acid as prophylaxis, the incidence of having childhood acute lymphoblastic leukemia in children to be reduced drastically. Clinical presentation of megaloblastic anemia. Clinical presentation of megaloblastic anemia. Folate and B12 deficiencies are second form of nutritional anemia in the world and is only second to iron deficiency anemia. The major difference in clinical manifestation between these two, that is megaloblastic anemia due to B12 deficiency and megaloblastic anemia due to folate deficiency. The major difference is that most times megaloblastic anemia due to B12 deficiency, in addition to other symptoms present, clinically also manifest neurologic symptoms. And like I explained, this is because B12 is needed in the conversion of methylmalonic acid to methylmalonic CoA to succinyl CoA is needed as a coenzyme there in form of 5-adenosyl cobalamin. When vitamin B12 is lacking in the system, methylmalonic CoA accumulates, and this methylmalonic CoA, accumulation of methylmalonic CoA affects the nerve, causes demyelination of the nerves and the axons, causing the neurologic symptoms that we can observe in B12 deficiency. The vitamin B12 stores in the body are so large relative to the daily requirement that it takes years of inadequate supply before clinical symptoms develop. But in contrary, on the other hand, symptoms of megaloblastic anemia due to folate deficiency can occur within few months after its supply is diminished. Unlike folate deficiency, like I said earlier, B12 deficiency is associated with neurological symptoms. These symptoms result from degenerative changes of the dorsal and lateral columns of the spinal cord, that is subacute combined system disease, and have been attributed to the impairment of myelin synthesis due to the accumulation of methylmalonic CoA or impairment of methyl group metabolism. The clinical symptoms of B12 deficiency, you have atrophic glossitis or shiny tongue as shown on the slide, you have shuffling broad gait, anemia, example megaloblastic anemia, vaginal atrophy, that is dryness of the vagina due because it affects the epithelial surfaces. Jaundice, personality changes, and then can also have neurological symptoms. And then because of the neurological symptoms, you can have memory loss, numbness, weakness, and then loss of dexterity due to loss of vibration and position sense. Systemic neuropathy of the legs and arms. Some of these symptoms can also be exhibited by folate deficiency minus the neurological symptoms. So you can have weaknesses and also megaloblastic anemia, shiny tongue, glossitis, and other jaundice and others as a form of folate deficiency, but neurologic symptoms can only be observed clinically in B12 deficiency. And there are other things that can also cause neurologic symptoms, but B12 deficiency is actually one of them. Now let's look at laboratory findings. What are the things we find in laboratory that will make us diagnose the patient to having a megaloblastic anemia? It is worthy to know that impaired DNA synthesis in megaloblastic anemia slows down nuclear replication and slows down cell division, and this leads in extension to what we call ineffective erythropoiesis and also premature destruction of red blood cells in the system. So, you know, because that is delayed DNA synthesis, and this slows down nuclear replication and also cell division, and it causes ineffective erythropoiesis. The cells that are being produced are not normal. So, and when red cells that are, once red cells are produced and they are not morphologically what they should be, the system has a way of removing them from system. The spleen will pull them out and destroy them, leading to increased destruction of red blood cells in the peripheral blood. So, and when the red cells are destroyed in the peripheral blood, one of the end products that we observe is that in catabolism of red blood cells, a byproduct, one of them is bilirubin. So you have increased level of bilirubin in the system, And as a result of destruction of that red cells, you can have anisocytosis, poikilocytosis. That's red cell fragmentation and also differences in the shape and size of the red blood cells. So anemia caused by either deficiency of either folate or B12 are characterized by macrocytic erythrocytes in the peripheral blood. So predominantly what you will see in the peripheral blood is macrocytic erythrocytes and hypersegmentation of neutrophils. You see macrocytic erythrocytes. So most times B12 and folate deficiency leading to megaloblastic anemia. Megaloblastic anemia can also be called macrocytic, as an example, a form of macrocytic anemia. So it is characterized in the peripheral blood by macrocytic erythrocytes. That's erythrocytes that are bigger than what they should be, with MCV above 110 femtoliter, and hypersegmentation of neutrophils in the peripheral blood, as well as in the bone marrow. You have megaloblast. You also have macro-ovocytic anemia, that is macrocytic anemia, and elevated serum bilirubin. And I have explained that elevated serum bilirubin is due to increased destruction of red blood cells in the peripheral blood because there is ineffective erythropoiesis. And when there is ineffective erythropoiesis, the red cells that are eventually produced is grossly abnormal. So the body will actually have a way of pulling them out of the system, leading to increased production of bilirubin, which is a byproduct of red blood cell catabolism. In severe cases of megaloblastic anemia, you have numerous nucleated red blood cells being present. Remember, in compensated anemia with active bone marrow, the body will try as much as possible to compensate, and in the process, pushing out more of immature red cells in the system, which is actually nucleated red blood cells that we see in the system, because mature red blood cells do not have a nucleus. The granulocytic series are also affected, and they show nuclear cytoplasmic asynchrony with the presence of giant metamyelocytes in the bone marrow, and also bands and hypersegmented neutrophil in the peripheral blood. So it is not only the red cell, the red blood cells series that are affected, the granulocytes are also affected. Even the platelets are also affected because the megakaryocyte lineage may display nuclear hypersegmentation too. And there is mild to moderate myeloid left shift is also, you have it as a common feature of megaloblastic anemia, mild to moderate myeloid left shift. So in red blood cell, you have macrocyte, you have anisocytosis, you have anisocytosis, and also fragmentation, poikilocytosis, that's fragmented red blood cells. And also, you can also have homogeneous bodies, inclusion bodies like homogeneous bodies and couple ring and all that. And in granulocyte, you can also have hypersegmented neutrophils. Serum vitamin B12 is reduced in megaloblastic anemia, as well as serum and red blood cell folate are also reduced in megaloblastic anemia. And then you have elevated homocysteine in the system. You have elevated concentration of homocysteine because B12 and folate are needed in the conversion of homocysteine to methionine. So when the B12 is not there in form of methylcobalamin and folate is not there, there is accumulation of homocysteine in the system, which can also be secreted in urine in the form of homocystinuria. And this is actually used in diagnosis of megaloblastic anemia. Again, serum methylmalonic acid levels also increases only in B12 deficiency. This is because B12 is needed in form of 5-adenosylcobalamin in the conversion of methylmalonic acid to succinyl A. So once vitamin B12 is not available, you have accumulation of methylmalonic acid in the system, which among other things causes demyelination of nerves and axons, leading to neurologic system that is neurologic symptom that is normally observed in B12 deficiencies. And Methylmalonic acid assay can also be used in diagnosis of vitamin B12 deficiency. Again, forminoglutamic acid accumulates only in folate deficiency because tetrahydrofolate is needed in the conversion of histidine. So glutamate, when folic acid is deficient in the body, it leads to accumulation of forminoglutamic acid. And when this is done, it can be secreted in urine and can be used in diagnosis of folate deficiency. So B12 and folate deficiency can also be distinguished by either doing forminoglutamic acid assay or methylmalonic acid assay. Bone marrow sections and smears are shown to be hypercellular, and they reveal erythroid hyperplasia. There is often a shift to the left with numerous megaloblasts in the bone marrow. So this is the hallmark of megaloblastic anemia, and the presence of numerous megaloblasts in the bone marrow. Megaloblast erythroid precursors are larger than their normal counterparts. They show nuclear and cytoplasmic maturation and display coaxial nuclear chromatin and have more cytoplasm relative to the size of the nucleus, like we are going to see in the next slide. Bone marrow cellular with erythroid hyperplasia. As you can observe in this slide, we have several megaloblasts in this slide. This is a bone marrow film showing erythroid hyperplasia and megaloblast. Peripheral blood examination reveals the pancytopenia with increased MCV of usual 115 femtoliter and more. It can be more than this. And the smears, they do a blood smear, peripheral blood smear shows anisocytosis, poikilocytosis, macroovalocyte, and they also show hypersegmented neutrophils. Other features that you can observe are basophilic stippling, Howard-Jolly bodies, and occasionally Cabot ring. Like we have here, we have hypersegmented neutrophils. This film, peripheral blood film, is showing hypersegmented neutrophils and also macrocytes. Also macrocytes, hypersegmented neutrophils. Neutrophils that have more than 5 lobes. And this occurs as a result of delayed maturation of erythroblast, that is, and also nucleus of these cells due to delay in DNA synthesis. Peripheral blood also, we are seeing here, have hypersegmented neutrophil and also macrocytes in the peripheral blood, hypersegmented neutrophils, and also macrocytes. And you can see there is a reduced platelets. Let us look at laboratory investigation of megaloblastic anemia. What is it that we do in the lab that will enable us diagnose megaloblastic anemia? Diagnosis, one of the first steps that we do to diagnose megaloblastic is what we call complete blood count. And in addition, we do peripheral blood smear. So we look at peripheral blood smear and we do complete blood count. The complete blood count will tell us the hemoglobin level, which obviously will be low, the MCV, which obviously will be high, MCHC, MCH, which obviously will be low. And we now look at the peripheral blood film, and we have macrocytic anemia. That is, you need to see macrocytes in the peripheral blood, anisocytosis, poikilocytosis, and large oval red blood cell, which is called macrovalocytes, and then Howard-Jolly bodies, which is residual fragments of the nucleus, and then hypersegmented neutrophils, and in extension, you can have reticulocytopenia. You can have pancytopenia, that is reduced number of all the cell lines you have in the system, the platelets, the red cell, and then the granulocytes. So all these can be observed in the peripheral blood. You can observe whether there's pancytopenia. You can observe if there are adipocytosis, pericytosis, large oval residual macroovalocyte, and also macrocytes in the peripheral blood, like we showed earlier here, like we showed in the slide here. Now, this is the general test that you can do, looking at doing the complete blood count, looking at red cell indices, the MCV, MCH, and then the peripheral blood film will tell you that it's megaloblastic anemia. But you need to know what is actually causing it. Is it B12 deficiency or folate deficiency or both? So there are further tests you can do to actually say whether it is B12 deficiency or folate deficiency. So number one is what we call scaling test. In this scaling test, radioactive labeled cobalt 60 with vitamin B12, that 1 microgram is given orally. And in gastric atrophy cases, there is no absorption. Hence, the entire radioactivity is excreted in feces, and radioactivity is not observed in the liver. But in the case of nutritional deficiency, if the cause of the disease is nutritional deficiency, there will be increased absorption of the radioactive level there, vitamin. And this radioactivity can be found in the liver. And also it can be excreted in the feces and can be counted. What is the significance of scaling test? The scaling test is performed to evaluate vitamin B12 absorption and to distinguish various causes of its reduced absorption, such as whether it is due to pernicious anemia, gastrectomy, iliac disease, or intestinal bacterial overgrowth. So it's actually, scaling test is done to specifically diagnose B12 deficiency, and also to check whether the deficiency is due to reduce the absorption through the nutritional, our diet, or it's the result of the reduced absorption due to intrinsic factor deficiency, or absence of intrinsic factor, or due to presence of diseases in the stomach or intestine that can affect its absorption. Another thing that we can do is what we call Leukopak test. In this case, it's also done to diagnose B12 deficiency. It's also done to diagnose B12 deficiency. Another one is what we call homocysteine assay. Homocysteine assay that we've been saying can be done to diagnose both B12 and folate deficiency, because B12 and folate is needed in the conversion of homocysteine to methionine. So when there is deficiency of both B12 and folate, homocysteine accumulates in the system. So when you do homocysteine assay and it is elevated, you'll be suspecting B12 and folate deficiency in megaloblastic anemia. But if you want to differentiate whether it is folate or B12, you can go further to do what we call methylmalonic acid, because in this case, only B12 is needed in conversion of methylmalonic CoA to succinyl CoA. So in absence of B12, methylmalonic acid accumulates in the system. So when you do methylmalonic acid, in the presence of B12 deficiency, it will be elevated. But if, when you want to differentiate, if it is folate that you are suspecting, so you can go ahead to do forminoglutamic excretion test. Forminoglutamic excretion test is specifically for folate. It tells you that the megaloblastic anemia that you are observing is strictly as a result of folate deficiency and not B12 deficiency, because folate is needed in the conversion of histidine to glutamate. And when folate is not available, forminoglutamic acid accumulates in the system, and it can be excreted in urine and is used in the diagnosis of folate deficiency. Other tests that can be done are serum folate, estimation of serum folate, and red blood cell folate, and then serum cobalamin. You can go straight to estimate serum folate, and then red blood cell folate, and serum cobalamin. Remember, I said in hematology, our diagnosis is based on, first of all, doing our complete blood count, looking at our red cell indices, and also looking at our peripheral film, observing those features that are specific, that I mentioned here, especially for megaloblastic anemia, and then going further to do a confirmatory test, specific tests like scaling test, leukopak test, homocysteine assay, methylmalonic assay, pulmonary glutamic excretion assay, to actually know whether it is folate or B12, depending on the one that you are actually, the doctor is actually suspecting. Prevention, how is it prevented? It can be prevented by doing our diet simply as something as simple as dietary modifications. Breastfeeding, well, doing appropriate breastfeeding and using appropriate weaning diet in our infants will reduce incidence of megaloblastic anemia in children. And also eating vitamin B12 and folate-rich food, and also not overcooking our food, because folic acid or folate that is found in our food, they are labile, they are heat sensitive. So when we overcook our food, we tend to lose them. And then food fortification, that are various meals that can be fortified with folate, that will also help to alleviate folate deficiency in the system. And then when needed, your doctor can actually prescribe them. When needed, your doctor can actually prescribe them B12 or folate supplementation. B12 and folate supplementation. Thank you very much. I believe sincerely that you have learned something from this lecture. Please don't hesitate to keep sending in your feedback. Thank you very much for being part of this lecture. Thank you. Thank you.